Okay, welcome to my channel. Today, I want to share the importance of respiratory function test and pulmonary function test is commonly asked in the MRCP exam. And the topic is I want to explore some importance of respiratory function tests in MRCP exam, and we'll go on to Pathology for that related topics. Okay, let's start with some brief anatomy of respiratory system. In general, we can divide the respiratory system into upper respiratory system and the lower respiratory system. And the upper respiratory systems, there will be nose, nasal cavity, and the nasopharynx and oropharynx and laryngeal pharynx. And lower respiratory systems, there will be the tracheal, bronchus, right main bronchus, left main bronchus, and the bronchioles, and the alveoli. So, to detect the difference between upper airway obstructions from lower airway obstructions, we need to know flow volume loop. Here you can see the diagram of flow volume loop. In the y-axis, that is a flow, and the x-axis, that is volume. And the volume means the volumes or lengths. And combinations of volumes, there will be the vital capacity, and let's talk about it in the later slide. Okay. In the flow volume loop, there is a phase of respiration like inspiratory phase and the expiratory phase. Here you can see the inspiratory phase. It is the active process. Let's imagine that in case of inspirations, there will be negative intrathoracic pressures in our body. So oxygen came into our lungs, and there is curve will be like this. And then leads to the expiratory phase. And expiratory phase is a passive process, and there will be no more effort for explorations. So there's a passive process, and the curve will be like this. So here you can see the inspiratory curve, and here is the expiratory curve. In expiratory curve, there will be the negative intrathoracic pressures like -1, -2, -3, etc. And if you breathe in, a curve will move up to 0, and then up to +1, +2, and then there will be expiratory phase. This is the typical and the characteristic of flow volume loop. Okay, so let's see some pathology here. Here you can see the various diagram of flow volume loop. This is normal, shown in the black, and a COPD with green color, and fibrosis with the amber colors, and the blue color with the tracheal obstructions. In these abnormalities, that is very clear that tracheal obstructions, like upper airway obstructions, totally different from our normal flow volume loop. Here, you can see the curve of the inspiratory and the expiratory phase. Let's imagine that there is upper airway obstructions. There will be no more air came into our lungs, and there will be no more air came out of our lungs. So there will be no difference between negative intrathoracic pressure as well as positive intrathoracic pressures. So the curve will show like that. So it is totally different from our normal flow volume loop. And also, there is also expiratory phase. And normally, expiratory phase is a passive process, but in case of upper airway obstructions, it's necessary to use effort. So curve will show like that. Okay, and then this is the obstructive airway disease like COPD. In COPD, there will be air trapping in our lungs, in our alveoli. So there will be prolonged expiratory phase, and the curve will show like that. And in case of fibrotic lung conditions, there will be reduce in our lens volumes, and curve will be shown like that. There will be reduced in the volume as well as effort of explorations and inspirations. So there will be reduced in the flow of our flow volume loop. So here you can see different pathologies and different diagrams of the flow volume loop. But the prominent one is the trachea obstructions. So in case of MRCP exam scenario, if they ask about how to differentiate upper airway from the lower airway obstructions, we need to use flow volume loop. Okay. So let's talk about it in the specified questions later. And here's another important thing you need to note about it. That is FEV1 and FVC. So what is FEV1? For expiratory volume within 1 second. And the forced vital capacity stand for FVC. Okay. But more important is the ratios of FEV1 and the FVC. You need to know that in our normal lens, there will be a value of more than 70%. That is normal. FEV1 by FVC ratios, more than 70% is normal. Also, it can be found in the restricted airway disease. And you need to know something that FEV1 FVC ratios more than 70 also found in severe restricted conditions like obesities. Okay, and if the value is reduced and if less than 70%, that will be obstructed airway disease. So you need to know this value, and you need to note it. This is the normal and the abnormal conditions as well. Okay, another important thing is the respiratory function test. So here you need to know before tests, during tests, and after tests, what will happen and what are the important things we need to know about it. Here, preparations for the test. There will be some false positive as well as some false negative in interpretations of the lens volume pulmonary function test. Here, if you use bronchodilators like salbutamol or the ibuprofen bromides, you may need to stop using it beforehand. It can be asked in MRCP exam questions. You should also avoid smoking at least 24 hours before test. Also avoid drinking, strenuous exercise, or eating large meals for a few hours beforehand. Also, method of spirometry like pulmonary function test is we need to breathe totally in, we need to breathe out totally. So it is necessary to wear the loose clothing on the day of the test. Okay, these are the preparations before pulmonary function test. It's very important. It can be added in the MRCP exam questions. You can see in the questions also. Okay. And here, these are the method of pulmonary function test like spirometry at the body, like desmography. Here, you can see the method of spirometry using the helium gas. It's very simple. A blow out to the machines, and the machines will detect like volumes, capacities, as well as residual volumes and vital capacity. Okay, but here, if lens is occupied by the bullet, there will be some error in the interpretations of pulmonary function test. In case you need to choose body like desmography, there's also the machines measuring pulmonary function test. So in your clinical scenario, if that is fully like clinical conditions, you need to choose body blood desmography, not helium dilution method. Okay. Okay, let's talk about very fundamental and important for the pulmonary function test. At first, you need to note there will be 4 volumes and the 4 capacities. Capacity means the combinations of volume. And you need to know each and everything thoroughly, and you need to note the male of the normal value. Okay, here, let's start with tidal volume. During normal respirations, there will be no effort in our respirations, so it is called tidal volumes. If we breathe in with effort, there will be inspiratory reserve volume. If we breathe out with the effort, there will be expiratory reserve volume. But it is important to know that there will be residual volumes because in our lungs, that is alveoli. Alveoli has a capacity of dilatations due to the actions of surfactants, type 2 pneumocytes, in other words. And it is very important. If we breathe out our air totally from our lungs, and the alveoli would collapse, and there will be no air entry, and our respiratory functions will be full, and we will get respiratory failure. So it's important to have residual volume, but there will be some pathology with increased residual volume, like obstructive airway disease. Okay, let's talk about it later. So here, tidal volume is 500 ml, but there will be little difference between male and female. And let's note it generally like 500 ml for male and female. Okay, tidal volume 500 ml, inspiratory reserve volumes 3000, and expiratory for 1200, residual volumes 1200 watts. Okay, this is our volumes, and the capacity is the combinations of volume. If we combine tidal volume with inspiratory reserve volume, there will be inspiratory capacity. If we combine expiratory reserve volume with residual volume, there will be functional residual capacity. If we combine these 3 volumes, we'll get vital capacity. And if we combine all the volumes, 4 volumes, we'll get total lens capacities. These are the volumes and the capacity we need to note theoretically. But in our exams, there will be some clinical important things like residual volumes, vital capacity, and the total lens volumes. You can see in the best of 5 questions later. Okay, so you need to note volume, capacity. What are they? What is the value of volume? Okay. Now let's move on to transfer factor. Transfer factors is one of the boundary function tests to detect the gaseous exchange in our alveoli. So let's see with this diagram. Okay, this is our alveolus, and this is our vascular endothelial layer. And between these layers, there will be a fibroblast-like tissues between these layers. This is called basement membrane. It's made up of type 4 pneumocytes. You can see black gas barriers. It's very important for the gaseous exchange in our body. It's consisted of body's pulmonary surface, alveolar epithelia, and theoretically there will be 9 layers, but you need to note alveolar epithelia, basement membrane, interstitials. Also, this is the layer between the alveolar epithelia and the vascular endothelial layer. Okay, here, vascular endothelial basement membrane, as well as you need to note the importance of gaseous exchange, component of the gaseous exchange like plasma. If the plasma volume is reduced like hypotension or cardiogenic shock, that will be reduced in the gaseous exchange. Okay, that's a very simple thing. Okay, here, in the alveolar basement membrane and lining epitheliums, there will be type of pneumocyte like type 1 is necessary for gaseous exchange, and type 2 pneumocytes, it would maintain its surveillance. Okay. If here, this is vascular endothelia. Vascular endothelia's entry into the pulmonary artery, that would be the deoxygenated blood. Okay. From that, carbon dioxide were removed from the airway, and oxygen will be breathed and carried by the hemoglobins to form the oxyhemoglobins. Okay, this is a very physiology and very fundamental things. Okay, this is the importance of gaseous exchange. To happen this, there will be a black gas barriers. I already mentioned about it. You need to note alveolar epithelium, basement membrane like interstitials, endothelial basement membrane, as well as plasma volume. Okay, to detect the gaseous exchange in our body, there will be tests like transfer factor. It's known as TLCO or TCO as well. That means CO means carbon monoxide, because in experimental tests we use carbon monoxide as it can bind to hemoglobin 20 times more potent than oxygen. But if you use carbon monoxide in the excess volume, there will be carboxy hemoglobins, and there will be hypoxias in our tissue. So 0.3% of carbon monoxide is used as an experimental test. So TLCO means carbon monoxide transfer factors, and the use of carbon monoxide is only 0.3%. Okay, so if we want to know the gaseous exchange in our body, we need to use transfer factors like TLCO. Okay. To know about it, you need to note the black gas barriers, like very important things, alveolar epithelials, interstitials, basement membrane, and the plasma. Okay, so these are the same example of reduced TLCO and increased TLCO. Here, you can see some pathology like pulmonary fibrosis. There will be the fibrosis of the interstitials, and the gas exchange will be reduced. It's very simple. And pneumonia is also, there will be alveolar edema, and there will be reduced gas exchange. And pulmonary hypertension, there is reduced blood flow from the pulmonary artery, so reduce in the plasma volumes and reduce TLCO. Also, pulmonary embolism has a similar mechanisms, and low cardiac output similar mechanism, anemia as well, and emphysema. Okay, here these are the causes of increased TLCO. It's nothing concerned with the black gas barrier like asthma and bronchitis. This is because obstructions of the obstructive airway disease, and nothing concerned with the black gas barrier. Okay, and the alveolar bleedings, that is increased blood flow from the vascular endothelium, and there will be more gaseous exchange, and the TLCO will be raised. And hyperkinetic states and left durations. From left durations, there will be more and more blood flow from the right ventricles to the pulmonary arteries, and then to the alveoli, and there will be more gaseous exchange. So increased TLCO. Okay. So you need to know the causes of reduced TLCO and increased TLCO. And here is the more important things that can be added in our clinical scenarios, like KCO. KCO means coefficients of carbon monoxide transfer factors. And it defines transfer factor expressed by unit volume is KCO. So KCO means TLCO divided by unit length volume. This is KCO. Also, it is important to know that it not only detect the pulmonary cause, but also it can detect extrapulmonary conditions like kyphoscoliosis and other neurological conditions. Okay. Here, this is KCO. KCO means TLCO divided by the unit lens volume. Let's imagine one thing, that if TLCO is reduced in case of pulmonary fibrosis, there will be reduced TLCO. Also, there will be reduced lens volumes. So KCO will be normal or reduced in advanced case of pulmonary fibrosis. Okay, so you can imagine that if we know the TLCOs, if we know the pathology of underlying lung disease, you can detect the KCO. Also, it's important to know that not only detect pulmonary cause, also extrapulmonary causes. Okay. And then we'll move on to VQ ratio, ventilation perfusion ratios. Normally, 1 liter of air entry into our alveoli within 1 minute, and a 5 liter blood flow came to our pulmonary artery within 1 minute. So if we divide it, we'll get 0.8%. That is our normal PQ ratio. Okay, the important things of PQ is it can be added in the pulmonary embolisms. Okay, so in case of pulmonary embolisms, volume of air enter into the alveoli is normal, but there will be the reduce in the flow of blood into the pulmonary. So blood flow will be reduced and the ventilation is normal. So PQ ratios will be increased. Okay, this is one of the examples you need to note. Okay, here you need to note the normal value of PQ ratios is 0.5. Okay. This is our lens. Normally, ventilation is more prominent in the lower lobe. Sorry, perfusion is more prominent in the lower lobe. Okay, because according to the gravity effect, right? So there will be more perfusions in our lower lobe. For ventilations, it is more prominent in our upper lobe. So if we ratio this value, we get normal value like PQ ratio from 0.3 at apex to 0.63 at the base. Why? Here you can see in our upper lobe, PQ ratio, ventilation is more than the lower lobe, and the perfusion is reduced. In our lower lobes, PQ ratios is ventilation is reduced and the perfusion is increased. So if we find the difference between these ratios, you would get the value of 0.3 at the apex and 0.63 at the base. So you need to know that PQ ratio is much more in the apex than the base of our lens. Okay. And these are the commonly asked questions in MRCP exams and the interpretations of the pulmonary function test abnormalities. So let's talk about it briefly here, and then we'll move on to best of 5 questions later. Okay, these are the some important pathological conditions you need to note in associations with the pulmonary function tests. Here, asthma, chronic bronchitis, and emphysema, these three conditions associated with obstructive airway disease. So there will be reduced FEV1 by FEZ ratio like less than 70%. In case of pulmonary fibrosis, FEV1 FEZ ratio is more than or equal 70%. So there will be normal or there will be increased than normal. So how about TLCO? TLCO means that I already mentioned about it. Transfer factors, that means gaseous exchange of our alveoli. In case of asthma and chronic bronchitis, TLCO is no change, just normal. In case of emphysema, there will be reduced TLCO. Okay, because in case of emphysema, there will be pathology like destructions of the fibroblasts and elastic tissues, and there will be destructions of our basement membrane. So reduce gaseous exchange and the reduced TLCO. In case of pulmonary fibrosis, interstitials is fibrosis. Fibrous tissue is filled with the interstitials, and that will reduce TLCO. Okay, how about KCO? This general thinking, if TLCO is normal and the KCO is likely normal in case of obstructive airway disease, that in case of pulmonary fibrosis, KCO is divided of TLCO by unit lens volume. In pulmonary fibrosis, TLCO reduce and the lens volume also reduce. That will be normal. But in advanced fibrosis, KCO will be reduced. So in pulmonary fibrosis, KCO may be reduced or maybe normal. Okay. How about total lens capacity? Total lens capacity is the combinations of four volumes. If there will be something change in one volumes, there will be change in the total lens capacity. Okay. Let's talk about pulmonary fibrosis. In pulmonary fibrosis, there will be reduced and there will shrinkage of our lens volumes, and the volumes, totally four volumes reduce and the reduced TLCO. Just very simple. But here, obstructive airway disease like asthma and chronic bronchitis, TLCO is no change. That very prominent features is emphysema. In emphysema, there will be air trapping. There will be an elastic distortions, and there will be an air trapping in the alveoli. So there will be increase in the residual volume. And if we combine the four volumes, including residual volume, total lens capacity will be increased. Okay, so in these conditions, residual volumes is markedly increased in the emphysema. Also, TLCO is also increased. Okay, so let's talk about it in a best of 5 questions. Here is also very important in MRCP exam. Not only the respiratory system, it can be as in basic medical science like biochemistry sections. Okay, this is our oxyhemoglobin dissociation curve. In the above, I already mentioned about the gaseous exchange of our oxygens and control breathing. And here, I want to tell about the fate of oxygens. What will happen after release from the alveoli? It will enter into the arterial blood, and what will happen? Let's see about it. This is our alveoli. This is our vascular endothelia. This is our oxygenated hemoglobin. In other words, it is oxyhemoglobin. Hemoglobin plus oxygen. So what does his do? It's very simple. Hemoglobin will carry the oxygens and it will relate to our tissue. Here is our tissue. Oxygen will be given to our tissues and carried by hemoglobin. So to detect it, there will be oxyhemoglobin dissociation curve. Okay, we need to know some terminology in here. If hemoglobins bind with oxygen, it is called binding affinity. Okay, and then if hemoglobin is given the oxygens to the tissue, binding capacity will be reduced. If there's no binding capacity, will be increased. Okay, here, let's see our normal oxyhemoglobin dissociation curve. This is black line. You can see here. In the y-axis, there is percent oxyhemoglobin saturations with oxygens, and in the x-axis, there will be partial pressure oxygens. And this is our venous blood level. In this level, hemoglobin must be deliver the oxygens to our tissue. That's a normal mechanism. Okay. Here, from the alveolar lines, oxygen was carried by the hemoglobins in the arterial blood. It's round about 100, but it's not too much. There will be 97% or 98% because there will be some physiological change in our body. So around about 98, okay? And the tissue levels here, this is our tissue level. Here is a partial pressure of oxygen around about 40. In our tissue levels, oxygen need to give to tissue by the hemoglobin. So in tissue level, there will be binding capacities reduced. In the arterial level, binding capacities increase. Okay. Here, the curve will be like the sigmoid shape, and it's called boat effect. Okay. This is normal oxyhemoglobin dissociation curve. If curve is moved to the right, curve is moved to the left, what will happen? And what are the conditions associated with these abnormalities? You need to know that. That's a very important question, commonly asked in a MRCP exam. In case of right-shift curve, that will reduce oxygen affinity of hemoglobin. Because in right-shift conditions, you can see here, low pH like acidosis, increased CO2 like respiratory acidosis, and high temperatures and high 2,3 ppgs. Well, what is that? 2,3 ppg is ready from our red blood cells in case of tissue hypoxia. Okay. So these are the conditions associated with tissue hypoxia. So if tissue hypoxia, there will be oxygen much more necessary for tissue for metabolism. So this right-shift curve means hemoglobin is less bind to oxygen and it was given to our tissue. This is right-shift curve. But in case of left-shift curve, like alkalosis and low temperatures like hypothermia and the hemoglobin and abnormal hemoglobinopathy like thalassemias and the methemoglobinemia, oxyhemoglobinemias. In these conditions, hemoglobins bind to oxygens avidly, and there will be reduced oxygen delivery to tissue. So curve will shift to the left. Okay. So these are the oxyhemoglobin dissociation curves and the abnormalities. You need to know the condition associated with right shift curve. You need to know the condition associated with the left shift curve. Okay. So let's move on to pathology. This is our respiratory failure. What is respiratory failures? Respiratory failure is used when pulmonary gas exchange fail to maintain normal arterial oxygen and carbon dioxide level. But the important thing is can be classified into type 1 and type 2 according to the level of PaCO2. Before that, let's move on to control breathing. There's a stimuli, very important things, very important stimuli for respiratory effort. Okay, and you can see some example like pulmonary fibrosis. In case of pulmonary fibrosis, there will be a stimulations of stretch receptors in our rib cage, and it is transmitted to central chemoreceptor or maybe carotid body. That you need to know that if there will be increased PaCO2, is more effect on the central chemoreceptor. If there is hypoxia, like reduced PaCO2, there will be more stimulations of carotid body. Okay, so these are the respiratory stimuli contributed to illness. So we need to note some conditions and some example associated with type 1 and type 2 respiratory failure. Also, here are some data you need to note. How about normal value of arterial blood gas? That is a normal value of our arterial blood gas. pH is around about 7.35 to 7.45. PaCO2 is 10 to 13 kilopascals. PaCO2 4.5 to 6. Pica 22 to 28. Okay. These are the important things you need to note about arterial blood gas, but sometimes it can be shown in a scenario. Okay. Okay, you can see that these are the same conditions associated with the respiratory failures, type 1 failure and type 2 failure. In generally, you can be noted type 1 failure associated with VQ mismatch. Type 2 failure associated with alveolar hypoventilations. Okay, here is type 1, some causes of type 1 failure, like asthma. Pulmonary edema, there will be VQ mismatch. Okay, that will reduce in the ventilations. So if we ratio the VQ, there will be mismatch value, and it will be reduced than normal. And pneumonia also, and collapse, pneumothorax, pulmonary embolisms, and the ERDS. And these are the some of the pathology associated with type 1 respiratory failure, and also pulmonary fibrosis and right to left shunt. Okay, these are the type 1 respiratory failure. And type 2 respiratory failure, underlying pathology is alveolar hypoventilations. How about type 2 respiratory failure? In case of type 2 respiratory failure, there will be alveolar hypoventilations and the carbon dioxide washout will be reduced. So PaCO2 will be increased or normal. Okay, so in case of type 1 respiratory failures, PaO2 is reduced, also PaCO2 is low or normal. In case of type 2 respiratory failures, PaO2 reduced, PaCO2 is raised. Okay, in the clinical scenario and in the later, you can see PaCO2 level, PaO2 level. If PaCO2 is raised, you need to know the pathological causes of type 2 respiratory failure. Here you can see not only the pulmonary cause, but also the effort of respirations is important in the control of type 2 respiratory failure, like hyposcoliosis, myopathy, muscular dystrophy, like narcotic drugs that will reduce in the ventilations, and also chest injury. There will be effect in the carbon dioxide exhalations. Okay, so these are the same examples associated with type 2 respiratory failure. But it is important to know that there will be acute conditions and chronic conditions. That means compensations of type 2 respiratory failure. In type 2 respiratory failures, there will be increase in the PaCO2. According to the body homeostasis, there will be metabolic alkalosis. Okay, if that is metabolic alkalosis, bicarb level will be raised. That's called compensated type 2 failure. In case of acute, it is acute type 2 respiratory failure. So if there is compensations, bicarb level will be raised. Okay. So you need to know some of the causes of type 2 respiratory failure. Okay. Here are the same clinical features associated with the respiratory acidosis. Because of the carbon dioxide retention in our body, that will be tropic headache because of vasodilatations effect, and other conscious levels cause of increase in the carbon dioxide level in our blood-brain barriers in our brain that will reduce conscious level, and the hyperrefluxious, clumping traumas, cyanosis, and bounding pass cause of vasodilatations and warm peripheral as well, and the bubble edema. These are the features of respiratory acidosis, cause of the carbon dioxide retentions. Okay. So that's all about pulmonary function tests. So let's recap it. In pulmonary function tests, I already mentioned about the importance of flow volume loop to differentiate upper and lower airway obstructions conditions. And importance of FEV1 by FE0 ratio and the normal value, and importance of flow volumes and the importance of flow capacities, and the importance of gaseous exchange by means of TLCO and the KCO. Okay, these are the same clinical conditions, and the importance of oxygen dissociation cuff. That means oxygenated hemoglobin is given to the tissue level. Okay. And same pathology like respiratory failure, you need to note the normal value of arterial blood gas. Okay. So let's start with some example from some study materials like on exam and the past medicine. Okay. This is one of the questions. List below are the 5 causes of hypoxias. Which one of the 5 inevitable causes and increased PaCO2? That's mean type 2 respiratory failure. So it's very clear that type 2 respiratory failure is associated with alveolar hypoventilations. So the answer will be hypoventilations. Okay. And here's another question. 40 years female presented with shortness of breath, cough, heavy sputum productions, and a low grade fever. And questions likely pneumonia. Okay. She has smoked 20 cigarettes per day for 30 years, and then arterial blood gas show pH normal value, PaCO2 is raised, and PaO2 is reduced. So this is also type 2 respiratory failure. Okay, you can see there's 5 questions here. Asthma is associated with type 1 respiratory failure, chronic bronchitis, type 2 respiratory failure, fibrosis type 1, paraneoplastic syndrome also type 1, and pulmonary embolism is type 1 failure. So the answer will be chronic bronchitis. So here, in restricted lung disease due to respiratory muscle weakness, which of the following statements true? So in case of respiratory muscle weakness, there will be type 2 respiratory failure. But the question is about the volumes and the capacity of our body. Here, like respiratory muscle weakness, like myasthenia gravis. Okay, let's imagine that there will be nothing concerned with FEV1 and FE0 ratios because it's not obstructive airway disease. So A and B is not in our answer, and low vital capacity, low FEV1 for expiratory volume within 1 second associated with obstructive conditions is not concerned with these questions. So there's only D and E. Here, low vital capacity, low residual volumes, and low total length capacity. Okay, and then number E is low vital capacity, low total length capacity, high residual volume divided by the total length capacity. Okay. In respiratory muscle weakness, like myasthenia gravis, there will be type 2 respiratory failure, right? In case of type 2 respiratory failure, there will be alveolar hypoventilations. Alveolar hypoventilations means some of the air is trapping in our alveoli. Okay, there will be increase in the residual volume. So high residual volume, that will be the correct answer. Because low residual volume is not light in this clinical scenario. Okay, so the answer will be, the correct answer will be E. Okay, and these are difficult questions also. Here's another example. 21 years old female, emergency with acute, an oral history of chest tightness, dyspnea, tingling in her hands and lightheadedness. She has neither past medical history or family history or note. Examinations is elevated respiratory rate also. And saturation is normal. Chest is also normal, and ABG show like that. pH is raised. Okay, PaCO2 is reduced, PaO2 also reduced, and the PiCap is normal. So what is the likely diagnosis? Okay. In case of acute asthma attack, there will be type 1 respiratory failure. Okay, but yes, there will be type 1 respiratory failure. In case of type 1 respiratory failures, PaCO2 also PaO2 is reduced. But according to clinical scenario, is unlikely asthma, because in case of asthma, there will be wheezing or there will be chest tightness. Okay. How about hyperventilations or psychogenic case? It's more likely in this case. Chest tightness, dyspnea, young female also. Chest tightness, dyspnea, and tinglings may be associated with hyperventilations or psychogenic hyperventilations. But in case of hyperventilations, there will be more and more carbon dioxide washout from the body. So PaCO2 will be reduced, but PaO2 will be normal. Okay, so it's not also the answer to. How about pulmonary embolisms? Pulmonary embolism is associated with type 1 respiratory failure. PaO2 as well as PaCO2 will be reduced. That may be the correct answer. Let's see another stem. Respiratory muscle weakness is unlikely because it's associated with type 2 respiratory failure. And how about volume depletion? In case of volume depletions, there's nothing concerned with the PaO2 as well as PaCO2. So the correct answer is pulmonary embolism. So you need to know these questions. This is very commonly asked in MRCP, and easily make a mistake because it is type 1 respiratory failures, and clinical feature is more likely with hyperventilations, psychogenic dyspnea. But to differentiate it, you need to know that in case of hyperventilation or psychogenic hyperventilations, PaO2 is normal. Okay. Okay. You are reviewing chemical pathology results, which have come to use acute medicine imports and collecting serum from patients' chronic respiratory failure. Which one of the following will fit best with a compensated respiratory acidosis? So these are the answers then for these questions. Compensated respiratory acidosis. So you need to find out the acidosis of pH here. So in case of respiratory acidosis, there will be reduced pH. Okay. Here, as you can see, here, also here. Okay. So due to the respiratory acidosis, there will be increase in the PCO2. Normal PCO2 is 4.526. How about stand 1? PCO2 reduced is unlikely. PCO2 is 3.9, also unlikely. PCO2 is 3.8, it is unlikely. PCO2 7.2, that will be the answer. Because to interpret arterial blood gas, you need to interpret retrogradely. Acidosis at first, and acidosis due to what? Maybe respiratory or maybe metabolic, and then there will be a compensation or not. So you will get the questions correctly. Okay. Here is 80 years old coal miner who stopped walking 16 years previously, present with deteriorating dyspneas, and the FEV1 by FVC ratio is 0.5, right? 0.5, that is obstructive airway disease. Because normal value is more than 70%. So it's clear that likely diagnosis is COPD. This is obstructive airway disease conditions. Okay. And here, 62 years old man chemistry claim with increasing shortness of breath and the dry cough, walked previously in the ship bathing in deck 3. Examinations, mild shortness of breath at rest, finger clapping, bilateral inspiratory crack or auscultation of the chest, and pulmonary function test, that is TLCO is reduced. TLCO meant for TLCO also. And which of the following likely modes to affect the interpretation of the test? So it's very easy questions. Smoking on the morning of the test. Okay. And another example, the patients present to the chest clinic with 8-month history of cough, progressive shortness of breath. FEV1 is 1.7, and the ratio of FVC ratio is 0.7%. So that would be a normal, or that would be restricted airway disease. Okay. Which are the following conditions associated with this lens function picture? Number 1, bronchiectasis. It is not condition associated with like that. Emphysema, that will be reduced FEV1, FVC ratios. Obesity, maybe the questions, maybe the answers. Obliterative bronchiolitis associated with increased FEV1, FVC ratios, also pneumoconiosis. So the answer is obesity. So you need to note, in case of restricted airway disease, obesity is one of the examples. Okay. So these are straight questions. Condition associated with foreign TLCO. Okay. Good posture syndrome associated with pulmonary hemorrhage. So there will be increase in the TLCO. Left direction also increase TLCO. Anemia is associated with reduced TLCO. But this may be the correct answer. Let's see later. Hyperkinetic state associated with increased TLCO, also exercise associated with increased TLCO. So the answer is anemia. So here is 74 years old man with thyroid cancer admitted with shortness of breath. Best investigation to assess for possible compressions of the upper airway. That's very easy questions. To differentiate upper airway from the lower airway obstructions, there will be flow volume loop. Okay, so the answer is flow volume loop. So today I'll share about the importance of respiratory function test or pulmonary function test, commonly as in the MRCP exam, specifically in the respiratory system, and also practice with some example from the study materials like on exam and past medicine. And we'll discuss about some pathology of respiratory system in the next week. Every Saturday, 10 a.m., I'm going to share some knowledge, some facts, some trick about the MRCP exam. If you find it's very much important for your exam, and then I think I hope you will enjoy my videos. And today it's about that. So let's see you in the next week.